here in El Paso, there's a huge demographic of patients, diabetic patients who develop wounds and who are at risk for infection, at risk for limb loss and an amputation. So I kind of developed a little niche for that. You know, not every patient needs an amputation with diabetes and an infected wound. Not every patient needs a below the knee amputation. So for me, I kind of gravitated towards that. And it goes back to my whole philosophy, right? These patients are a challenge, you know, and these patients can heal either conservatively, obviously, or surgically. You know, there's always more that can be done. Every single patient with diabetes seen by a primary care physician or internal medicine physician should be evaluated by a podiatrist at least once a year, okay? When we evaluate them, we do a risk assessment, okay? Is there any foot deformities? Do they have hammer toes? Do they have a tight Achilles tendon? Is there any biomechanical issues that would contribute to that patient developing a wound, right? So that's how we assess their risk score, okay? If they're at low risk, no deformity, no calluses, pretty straightforward, then yeah, we can see them, you know, a couple of times a year, okay? But unfortunately, in our demographic, we do have patients who have bunions, bony prominences, they got nerve damage because of the diabetes, so we have to follow them closely, because a lot of these patients are at high risk for developing an ulcer at some point during their life, okay? So at that point, if the patient's a diabetic, come see me, okay? Absolutely.